Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Hi there and welcome to The Connection. I'm Darren Kilroy.
And my name's Liz Jones, and we're really pleased to introduce this next podcast. It was recorded about 4 weeks ago, Darren?
Yeah, it was recorded at our Connected Healthcare Summit in Manchester, which was a really great event, extremely well attended, and we were fortunate at that event to have Alison Leary with us, weren't we?
Yeah, absolutely. And Alison has done a lot of work over the years. Many people listening will be familiar with it in terms of work around staffing, workforce levels, but particularly work around nursing and how various roles are recognised appropriately, described appropriately, and a lot of work recently with the QNI to ensure that the technology that's introduced doesn't also introduce taskification of roles. So it's a great conversation, and I think it gets right to the heart of what we're trying to explore in this podcast.
Sure, I agree. And Alison's background, as she'll explain in the podcast herself, in engineering is particularly interesting in this respect. But anyway, hope you enjoy the podcast. Here it comes.
Today, I'm joined again by my colleague, Darren Kilroy.
Hello there.
And we're really delighted to come to you directly from the Connected Healthcare Summit in Manchester, a little bit in Salford. Apparently, it crosses the bridge between the two. And we're joined by Professor Alison Leary, who is someone that I've admired for many years. I think people know that, and is one of the preeminent voices in terms of workforce research and planning, a nurse and a mathematician, and you're going to have to tell us a NASA story, Alison, but we want to get to know you. That is the whole point of the podcast, is we want to get to know you. So welcome.
Thank you. It's lovely to be here.
Fantastic. And you've been to quite a few of these summits actually with us in different countries as well, actually. Yeah. You've not been here long today yet, so I guess you'll get a bit of sense. But if you think back over the years that you've been coming to these, and you think about, we've talked about workforce shortages, we've talked about agency, workforce planning. I think we're now on the third plan around workforce since you and I knew each other. Yeah. Are you hopeful?
I think there's reason to be hopeful now. Yeah. I think we've seen some very small changes in policy, which is really good to see. We're seeing perhaps a bit more of a responsive government, which is also good to see. I think we were a bit of a dead end prior to the election. So I think there are some things. There were also some obviously very big challenges. The financial constraints that most organisations are under are very challenging. And it's interesting to see the range of technology that's available to sort of try to enable the use of human resources, some of which is great and some of which perhaps could do with some work.
Yeah, and I think we want to get into that with you, because all of us in all of our lives, we've all used pieces of technology where you go, just doesn't quite work for how I want to do this. And that no more so than in healthcare, it would seem, even right down to the hardware in which it's delivered on and where it is and the environment. So we'll definitely get into that. We'll get into that.
Yeah, it's really interesting listening to you guys just introduce the session there, because I think, let's be honest, it's not a visual podcast. We're all of a certain vintage. And when you think back to the earlier days of professional practice, certainly for myself, I'll just speak for myself then, where technology did not intrude in the professional lexicon in the way it does now. And it wasn't as obvious anyway. And I wonder, Alison, what your reflections are on, from your earlier professional days to now, which elements of technology have been most influential for you in your career to date, and which maybe have been on the periphery of what you've found useful? And if any comments you've got about what's been the most striking technological advances in your professional career to date that have really struck you? Oh, that's brilliant. I'm so glad that's on the desk now.
For me, I mean, because I started my life as an engineer, so I've kind of been surrounded by technology from a very young age. And then going into nursing, there's obviously quite a lot of technology even before we think about the sort of IT stuff. So you were used to pumps and working in intensive care and things like that. There was lots of technology. But it did specific jobs. It did specific tasks. The technology landscape now is completely different. And I think one of the things that I see is where we have the understanding of trying to do work and replace work rather than tasks. And that is somewhere that I think there's varying degrees of success. So for people like me, I handle very big sets of data. And that's just a magnitude of difference from when I started doing this in the early 2000s to now. We needed massive computing power and lots of different technology. And now we could pull out a RLDatix data set and look and mine that in an afternoon.
Yeah.
It's very different. So for me, I think it's things like the speed of processing and the availability of that sort of technology. In terms of clinical people, I think I've seen a move away from user experience compared to other industries. So we've seen perhaps more assumptions about work and what technology is needed than perhaps a reflection of user experience that we'd say in retail grocery, where you use self-checkouts, that kind of thing.
Yeah, it's interesting what you say, Alison. I remember one very brief anecdote from myself around technology replacing process was just taking people's blood pressures way back when you used to use a sphygmomanometer or whatever, so you know what I mean?
Yeah.
That. And squeeze up the cuff and listen for the and get the blood pressure accurately recorded. And while you were doing that, you were talking to the person whose blood pressure you were recording.
Yeah.
And that was very valuable interplay between you and the patient. And of course, with an automatic machine, you pop it on and then you can walk away and come back and it's done it. And so there's always been a balance for me around technology, around what use it ostensibly may bring to standardization of the process versus what it can take away sometimes from the value of what you were doing in a different way. So interesting, your reflections there are very striking to me.
And that's going to be particularly poignant when we start having AI more of the kind of like front of care rather than at the back of care or in the admin side of things. Are you involved in any of those kind of initiatives currently to look at what that might look like? Because it's a big part of the potential funding on the 30th of October will be around, inverted commas, AI.
I think AI is really interesting because obviously we're seeing it in lots of different industries. Any kind of service industry now, you interact with a chatbot before you interact with a human generally. I think one of the things about AI, though, in healthcare, and I was actually in Boston last week discussing this with quite a lot of people that do a lot of this work. They and I have concerns around the quality of data that is being trained on. And if you don't train AI properly, and the emphasis in terms of policy seems to be about we don't have enough clinical people, so let's replace clinical people with AI. But actually, there are huge amounts of labour that are consumed in healthcare that could be automated.
Yeah.
It just isn't very kind of sexy. So people don't tend to do it. There are a few people around at the moment kind of looking at that, but that would save huge amounts of clinical labour.
Yeah.
And also make people happier, actually.
Yeah, so potentially using it, pointing it in a different direction towards more of the administration and clerical support so that the clinicians didn't have to do those parts, maybe. Is that where you're thinking? Or?
Yeah, I mean, we analysed coroners' prevention of future death notices a couple of years ago, and we found that misdelayed or uncoordinated care was one of the most cited concerns. And then when you look at the real world situation, you find clinicians trying to safety net and keep diaries and try to capture all this work and almost be like the project managers of care. This particularly affects nursing, but it affects also people like GPs. And I think there's some scope there to actually develop products that support that. But you don't really see the kind of interest in that sphere of work, but they would be really quite enabling pieces of work to do.
And it is interesting because in other industries, those kind of innovations are being adopted actually at the front line rather than corporately.
Yeah.
It's part of what happens in the NHS in particular, that actually IT becomes this corporate thing rather than a people. Right, okay.
Absolutely.
How would you change that?
Employed.
Yeah.
So unlike most other industries where the IT is developed usually with the people that are using it, the NHS particularly procures things and then deploys it onto the workforce.
I think that's spot on. It's so true.
Yeah.
Because I was just thinking about all my clinical years, just as you were talking there, I thought that's so true. Because you're expecting clinicians to weave their way around some technological wizardry and make it, inverted commas, work.
Yeah.
Without actually necessarily asking them, or moreover, patients, what it is that's required to make that piece of work, that process more straightforward and more efficient or of higher quality, let alone more safe.
Yeah. And we often do workforce impact assessments, and we've done a few actually. We did one for some of the IT that's deployed in areas like district nursing. And it was actually a leaving trigger. And we found this, we published a paper recently on this, that things that don't enable people's work make them leave. They make them want to leave. So they become a contributory factor. And I think that's why there's definitely benefit about developing technology with people that use the technology and see what their purpose and what kind of issues it can solve for them. Yeah.
Would you go as far as to say, Alice, that's the rate limiting step in its ultimate utility, is the ease with which it's available. In practical terms, you can use it day to day, hour to hour. The ease of use is fundamentally what will dictate its ultimate success.
I think essentially, in terms of penetration into the market particularly, yeah. I mean, the ease of use is one thing, but also it has quite an insidious impact on the workforce. So we are seeing people leave NHS jobs, but for many different reasons. But one of them is they are not enabled to do their work. So the constant investment in technology that is not fit for purpose, essentially, is actually having a very negative effect on the workforce. Now, what you then get is what people call institutification. So essentially, we have the technology then becomes the driver. So the automatic blood pressure monitoring is a really good example. So now you've got automatic blood pressure monitoring. You can delegate that work now to a lower paid, lower qualified worker, but they won't be able to do the things that you are able to do in terms of their interpretation of the more subtle signs, because they haven't been trained to do that or educated to do that or have the experience to do that. So what you then see is a degradation across the board, actually. So it's actually more than people having a bad experience of work.
You're absolutely right, because it takes me back, and I won't pursue it any more than this, is just to reflect upon all the times I was taking blood pressures in the middle of the night or any time of day. And while you're performing that, ostensibly laborious task that machinery can, let's assume, make more straightforward and more reproducible, you notice in the patient's colour, respiratory rate, affect, sweating or not sweating, any abdominal pain. They describe any number of factors that the machine will never be able to trigger because it doesn't know to look for them.
Exactly.
Yeah, absolutely.
Yeah.
It's interesting.
So we can take a little bit of a different turn for a minute and talk about data. So you've talked a bit about the quality of data and how important that is if we're going to really start using it. There's clearly a lot of data around. Right?
Yes.
There's no shortage of data. Do you think that the organisations, and I'm not just talking about the NHS here, but I guess you look at health and care across different countries, do you think that people are sophisticated enough to know the questions they want to ask of this data, or they're expecting it to spill the beans in some way through great work that people like you do with big data sets?
I think it could be perhaps more strategically designed. So in the UK, most of the countries collect data for performance purposes rather than looking at outcomes. But we do have pockets of that in places. So we have things like the cancer registry, and we have other sorts of data sets that are very specific, that were designed quite a long time ago by usually clinicians, but not always, that sort of sit within there but are quite hidden. And then when you join them together, you can get really good insight from them. And it's a bit like things like incident reporting. So the common classification system that products like RLDatix use, we know sort of where it can be useful and where we have to go and look in other places as well. Particularly the text in incident reporting is actually a lot more insightful than
Free text.
Yeah, the free text. Yeah. So we look for things like profanity, actually, or people datixing each other.
Yeah,
that's a red flag.
Yeah,
that is it's a cultural red flag. So there are things that you can look for, and it's just a thing about readjusting the data that's collected to make it fit the purpose you want it for, which is to get insight. At the moment, I think a lot of data is collected, and a lot of labour is expended on collecting that data, which could be automated, in terms of looking at performance.
That's interesting. And it is interesting, you talk there about the fact that sometimes there's these hidden depths, whether or not it's looking for different signs that are within it. Really, reporting is like nearly 35 years, as an instant reporting, is nearly 35 years old now.
Yeah.
And other than the forms getting bigger,
it
hasn't actually changed that much. Right, maybe the investigations after. One of the questions I've got is, do you think we might be on the cusp of something different where people start to use other data sources that mean that staff are talking to them about harms, and actually, and not only staff but carers and families, especially in the community? Do you think we might be on the cusp of something where people start to use wider data sources to understand what safety near misses are in their organisations? What's your view on that?
I think there's certainly the potential to do that. And this is one of the areas I think where these large language models and AI can be really, really helpful when you start to integrate those data sets, so you can really start to get insight. But obviously, if you're just recording harm, you're only recording one aspect of safety. And as James Reason famously said, safety is more than the absence of harm. So I think that in terms of iteration, it'd be a really good first step to look at that. If we look at other industries, so we'd look at all the routinely collected data, we'd look at all the performance data, we'd look at all the customer service data, we look at why people are complaining, we look at the social media. All of those things then give you more of a perspective and a much deeper perspective.
People deciding not to take certain shifts on certain days
Absolutely.
in certain areas all the time.
We'll talk about that today.
Oh, you're talking about that today? Oh, that's fantastic. Well, the listeners won't be able to go to that.
Oh, no.
They might be able to get the recording afterwards.
Exactly.
So obviously you do a lot of work with the Q&I.
Yes.
It's really, really positive to see that the new government seems to be really backing care closer to home. Sometimes a bit abstract what they mean by community, but that's what I've interpreted it as. What has to change, other than capital funding and funding in people, what has to change to make those things appear? Is it just politics, or is there something in the way leadership within the secondary care sector works?
I think there's obviously funding issues. The more money goes to secondary care than it does to primary and community care, despite the volume of work that's done in those two areas. I think the thing that needs to change, though, is really perhaps an appreciation of care in the community, because it isn't as visible. I don't think it's perhaps seen until it's not there.
It's not visible, is it?
No. And also I think there needs to be a change in workforce policy, actually quite a serious change in workforce policy. The long-term workforce plan still focuses on recruitment and supply, and those things are important, absolutely. But there isn't enough in there about retention, and there's almost nothing in there about getting people back into the workplace.
I found that in my latter days as an NHS medical director was that we were, especially post-pandemic, a huge attrition of senior doctors who just left the service with precious little attempt to retain them in their skill set, which we've lost literally forever. Around the experience in terms of mentorship, teaching, training, because they weren't able to operationally deliver a clinical outcome today. And because the operational imperative was so strong, there was no incentive to retain these professionals. And I know that applies to nursing and doctors. And for this and other reasons, of course, that generation of workforce have left the service. So you're right, Alison, in terms of the gap there. And I think about, because I was secondary care through and through, but had lots of primary care colleagues, of course, back in my NHS days of many years. And it was always a truism for me always was that I was in emergency care. 90% of emergency care happens in the community, not in the hospital. But the visible bit, as you say, happens in the hospital. And that attracts the funds. It's more straightforward to fund it. You can see the visibility of the outcomes, and politically that's more attractive. But that seismic shift that we need to preventive medicine is a very long overdue one.
And yet, the care that you receive in the community, or your family receives in the community, in all its guises, whether or not that's long-term conditions or otherwise, including end of life, is some of the most impactful on entire families. There's something really, and going back to, for the listeners, we had Victor talking this morning, there's something about telling those stories that's really important, because it just makes such an impact, doesn't it? Yeah. Right. I'm conscious of time. I'm probably not meant to say that on a podcast, but I am.
Every podcast, we could always spend an hour longer than the podcast allows for, because it just starts to get interesting as the podcast. And, oh my gosh, it's time to end.
It's been interesting all along. I wanted to ask you two things. One is workforce planning. So we've talked for years, and you talk about the poor workforce planning, this idea of taskification. Yes, of the workforce. I'm really conscious of this in terms of, I represent a software vendor. That is my job. And I know we've got the potential to contribute to that, and we've got the potential to make that better as well. Just, can you in a nutshell describe what you would expect of people like us, not just us, but people like us, to make this better, so that we avoid all these things like tech that doesn't allow professional judgment or the complexity of work to be really captured?
So the biggest challenge, I think, Jess has, so I'll often hear that we have more people working in NHS than ever before. That's absolutely true. But what we've lost is proficient workers. We have lost experienced workers. If we were doing workforce calculations, we'd add a 20% rookie factor on to, so that you need 20% at least of the workforce. And we are also probably one of the lowest OECD countries in terms of workforce. So I would say to any vendor, we saw this very much in the district nursing work, actually, who were being subjected to some scheduling platforms that were making them leave, is go and talk to the proficient workforce. Go and talk to the people that understand the work is done, see what they need, build it, and they will come.
Yeah. I love that.
Agree. Absolutely.
I love that. Yeah. And that's why it is important to work with not only those end users as proficient end users or clinicians, but also people like actually both of you to keep us honest, because it's important, because it's easy to have ideas in small boxes with glass windows. Yeah.
And I think fundamentally for a vendor or for anyone who wants to be involved in touching healthcare in any shape or form, from data analysis, if we remember, and obviously putting aside the need for generating revenue for corporate companies, all those things understood, if we root it in the advocacy for patients, that everyone is actually engaged in that fundamental endeavour.
Yeah.
That's why all the three of us in this podcast booth are doing what we're doing.
Totally.
It's when the day comes that healthcare touches us, we hope it'll be slightly better than the healthcare that touched our parents, and so on and so forth. And with that in mind, that's, I think, the fundamental to it all.
I agree. So there's all these jobs. One of the things we've talked about a lot is the fact that there's so many incredible careers in health and care. We could do an entire different podcast in terms of the education system of that, and also how you lead through to from places to places. It's maybe one for a different day. In terms of all these careers, you've got a number, haven't you, in terms of the job descriptions? What was that number on your?
In my data set, we have 77,000 job titles, but there are, I think, 350 sort of recognised roles, clinical recognised roles in the NHS, yeah.
And if you were sitting now in front of somebody, and you've had an interesting career, engineer through to nursing, if you were sitting in front of somebody now who was considering their options as what they're going to do for a career, what would you say about why these career in health and care is the one that they ought to be really seriously considering?
I actually think careers in health and care working conditions are not the best at the moment. I think everybody understands that. But the work is actually really good when you can do it well. And it is the most rewarding work that you can do. I was never bored, I have to admit. Challenged very often, but never bored. Worked with some great colleagues. Really felt I made a difference in the work that I did. And I think those things are still true. And I think now, even though things are difficult, there are still really good employers out there, actually. There are good employers who are trying very hard to make work for the people that work for them. And I would just say, go for it. Choose carefully who you work for.
Yeah.
Make sure that they value you as much as you want to work for them.
Yeah, brilliant.
Fantastic. Well, that's been really interesting.
Thank you,
short and sharp. Thank you so much. Thank you for being at Summit. And as always, we could have gone on for another 20 minutes, but really, really insightful. Thank you so much.
Thanks very much. Brilliant. Thanks.
Thank you.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.